Hey, this is Sandy.
And Randy.
And we're here on AT Corner.
Being an athletic trainer comes with ups and downs, and we're here to showcase it all.
Join us as we share our world in sports medicine.
Welcome to episode 6 of AT Corner.
Another education episode, and today is a little bit different because
Sandra's running this one.
This is crazy. I usually only run the stories, and I'm not a very big reader. Nothing like Randy, at least.
I'm super excited for this one. She really worked hard on this one.
So before we get into that, we do want to do a couple housekeeping. Something cool that we wanted to start with before we get into the education episode is that we're really excited to be in the podcast world. We were reached out to by multiple seasoned professionals. Jeremy Jackson from Sports Medicine Broadcast, Ryan Stevens from the Catalyzing Podcast for Athletic Trainers, Alicia Pennington from the Business Advantage Podcast, and Edwin Monroy from Active Variable. And we were given just the biggest warm welcome.
They were very supportive of us and offered any advice, any suggestions that they could give to help us out.
And I think that just highlights something so amazing about the athletic training profession is we're not here to compete with anyone. I'm very super competitive, but we're not here to compete with anyone. This is lifting athletic trainers up. This is promoting the profession.
And that's what everyone wants. All athletic trainers want this to, want the profession to keep developing and keep progressing forward.
Yeah, so we're super excited to be here. We're super excited that they reached out. And if you're looking for awesome content, head over to their podcasts and check them out. Cool, you ready to start?
Yeah, I'm ready to go. Let's do this.
So the reason why I wanted to look into asthma is, well, I did a little presentation on this for a weekly Zoom call we do with some other athletic trainers, which is super awesome. Shout out to Scott Tucker.
By the way, that just shows we love athletic training. We work it, we do the podcast, and we do some continuing education stuff with local athletic trainers.
Yeah, apparently we can't get enough. Can you tell? So basically the reason why I wanted to look into asthma and was mostly because of recent events. And, I've had athletes with asthma before. Should I actually just kick it off with a story?
What better way for AT Corner than a story?
Yeah, so when Randy and I moved, we moved 2 hours away from where we were living before, and we kind of moved a little bit, or Randy found out that he got this job, and we ended up moving, and it was kind of a weird time for me to find a job, because I had already been working in a job that I wanted to keep, so then I end up commuting 2 hours, which has got to be a little bit of a lot. And so then I end up just doing contract work because I didn't find full-time work, as well as I didn't really want full-time work down there. So during this contract work, something interesting about contract work is that we have no information on these athletes prior to working with them, really. Which is, sometimes it doesn't put you in a very good position, right? So I had this athlete, I was working a cross-country event, and she came up to me, was wheezing and coughing, and she couldn't really get too many words out. And I could tell that she was having some sort of respiratory, asthma attack. And one of the bystanders, I think someone was probably on her team or something, she came over and was like, she has asthma, she doesn't have her inhaler with her right now. And I think that the athlete actually had told someone where her inhaler was. It was in her car, so she was able to go, someone was able to go fetch that for her. But it was something that we don't talk a lot about in school is, usually your standard method of treatment with asthma is your inhaler. That's your go-to. But what happens if you don't have that? So I wanted to go over that today, and I wanted to touch a little bit upon asthma and masks.
Yeah, absolutely. And it's funny that you said that about it happening at a cross-country race, because that definitely is very common, and that's why when I'm at a cross-country meet with my athletes, I try, I know the ones that have asthma, I want them to give them my inhaler for when we're at the finish in the shoot. I can give it to them instead of making someone, go run and grab their bag. And so on and so forth.
Yeah, so normally, I know that we don't like to start out cut and dry, start out with the anatomy, but this one is very relevant. Kind of understanding where the respiratory tree is and what's kind of going on in the airway. So when you take an inhale in your nose and your mouth, it goes down through the trachea, which is cartilage, and then it splits off into left and right bronchus, and then it splits off into smaller cartilage tubes, which are bronchioles, and at the end of the airway, there are these little fluid-filled sacs called alveoli. They're filled with surfactant, so I'm actually not going to say that. That's just boring.
Hey, surfactant's cool. It makes sure your lung doesn't completely shut.
We're trying to get people to listen to here. And then those are within your lung. The right side is 3 lobes and the left side's 2 lobes. The way I remember that is because the heart is on your left side, so there's less space for an extra lobe there. And then that brings us to talk about, like, what is asthma? Well, asthma is a chronic inflammatory disorder of the airways that is associated with intermittent acute bronchospasms. And I know that usually when I listen to podcasts, especially educational podcasts, my brain cannot really focus on what that means. So the really biggest thing that I want you to take from the definition of asthma is that it's a chronic inflammatory disorder. Okay, so inflammation is going to play a huge role in this.
I think a lot of people forget about that is a defining feature of asthma.
Mm-hmm. Definitely. So with asthma, you're going to have excess mucus being produced and excess bronchial smooth muscle constriction. So remember when we were talking about the anatomy? The trachea, bronchus, bronchial alveoli. So the bronchiole is where that inflammation is going to take place. And I'll explain how that happens as well. But first, I want to go over the difference between exercise-induced asthma and exercise-induced bronchospasm, which are also terms that you're going to come across a lot. They're the same thing. So exercise-induced asthma, which is EIA, is the same thing as exercise-induced bronchospasm, or at least they're used interchangeably in most manners. Something I do want to note is that EIA, exercise-induced asthma, you can have that without having the chronic inflammatory disorder of asthma itself. So you can just have asthma during exercise. And I think that's something super interesting and super relevant for us as athletic trainers to talk about, because a lot of times we're working with people who are exercising, and a lot of times we're going to be seeing that exercise-induced asthma, which is more common than asthma itself.
So what exactly would cause an asthma attack then?
There are 4 main causes of asthma attack: pollutants and irritants. And by asthma attack, I'm talking about generic asthma as well as exercise. So pollutants and irritants, intense exercise or vigorous exercise, water loss in the airway, and thermal expenditure. So those are the 4 main ways. We're going to go back to these so you don't have to remember them off the top of your head. And we're going to go point by point. So first is pollutants and irritants. Pollutants and irritants, a lot of times for people, they cause allergies, but for asthmatics, the pollutants or irritants get into their airway, and that causes a release of inflammatory mediators.
Again, highlight the inflammation portion.
Yeah, so inflammation then causes bronchospasm, which is an asthma attack. We are going to see a little pattern here. So with intense exercise, there's an increased oxygen demand, right? So you're breathing more, you're needing oxygen more. There's an increase in tidal volume. So tidal volume is the normal amount of air inhaled and exhaled. So just think of like what you're inhaling, what you're exhaling, and add those together. That's your tidal volume. So you're increasing that. You're increasing on how frequently you're breathing. You're increasing the breaths per minute. So normally, what is that, 12 to 24 breaths per minute is normal?
Yes, I believe so.
So you're increasing that number.
And what happens with that increased breathing?
So all of this is happening. You're needing more breath. Just think about it. When you take a big breath, is your airway getting more dry or more moist?
I'm going to go with more dry.
Exactly. So your airway starts to dry out, because of that drying, now I'm going to talk about this a little. I'm just going to skip a step and just say the airway drying releases inflammatory mediators. I'm going to explain that in a second why. And inflammation then causes that bronchospasm. Do you see where this is going?
Exactly.
Back to that water loss idea. This is the third asthma attack risk factor. So with water loss, you have a rapid inhalation during exercise. Your bronchial mucosa begins to dry. There are changes in pH and osmolality of the fluid around the mucosal membranes. And I know that sounds like big words. So basically what I'm going to explain to you is that there are changes happening that release inflammatory mediators because the airway is beginning to dry. Does that make sense?
Yep.
So, release of inflammatory mediators. This is the third time I'm saying this. I hope you get where I'm going.
I'm guessing it's a key contributor.
Exactly. So when inflammatory mediators are released, that causes inflammation. When inflammation happens in the bronchioles, then we get a bronchospasm, which is an asthma attack. So this last one is the thermal expenditure theory. This one is a little bit different because it is not a primary risk factor for asthma. It's actually a secondary risk factor for asthma attacks. So basically what happens is when you are breathing, you're losing heat. This cools the airway down. So when that happens, the blood vessels in that area are enlarged. There's more blood in those vessels, which that brings heat.
Yep.
So every time you breathe, you're losing that heat. And because of that, there's going to be a bronchoconstriction. So instead of the inflammation causing the bronchoconstriction, it's the fact that you're losing that heat that is causing the bronchoconstriction. And the bronchoconstriction is then causing bronchospasm. Bronchospasm is an asthma attack.
So would that go into one of the reasons why cold triggers asthma symptoms?
Yeah, so cold, dry air is a really big risk factor for asthma attacks, and we'll talk about that a little bit later too. The biggest thing about risk factors, and I know that we've talked about risk factors in other education episodes before, risk factors for asthma are a little bit different because it's going to help you in your treatment plan.
Mm-hmm. So we went over the risk factors. So what would be the signs and symptoms of someone that is going through an asthma attack?
So this is really important because I feel like a lot of times when we learn about asthma attacks, we learn about the main, like coughing, wheezing, shortness of breath, chest tightness, physical activities being affected by breathing difficulty. And yes, asthma is a respiratory disorder, so we are going to see these respiratory symptoms. Now, those are specifically symptoms for exercise-induced asthma. So I think it's also important to note that asthma, the chronic inflammatory disorder, you can also see things like difficulty sleeping, breathing difficulty upon awakening in the morning, especially a family history of asthma, and a personal history of atopic dermatitis, eczema, or allergic rhinitis. And those things are important to point out because those are also inflammatory.
Yeah, and I would also like to add about the sleeping and awakening is a lot of the physicians that I've worked with, that is one of their history questions, whether the athlete has difficulty falling asleep or wakes up in the middle of the night short of breath. Those are big key contributors of, one, does this person have asthma? Or two, something that clinicians have to think about is their asthma management plan not effective anymore, and do we need to reestablish and maybe go on a long-term med?
Exactly. And we're going to talk a little bit about that too with the long term and when to see a physician, when to go to the emergency room, exactly all that. In our setting, we are lucky though because most of the time people are going to know if they have asthma. So you're going to have ahead of time knowledge. Now, of course, like when I was talking about the story that kicked us off, I was contracted to that event. So I don't know the history of that athlete. But she was able, or at least the bystander was able to tell me that this person did have asthma. So I was able to rule in that is probably what she's experiencing right now as a symptom of that asthma and not maybe like something else like anxiety, overtraining syndrome, vocal cord dysfunction, exertional GERD, like something like that, that are also things that we might have to consider.
Yeah, absolutely. So, as athletic trainers, we want to try to at least prevent incidents from happening. So, the how would you prevent the chances of an asthma attack?
So I really, especially when reading about this, like I didn't realize that asthma attacks are way more preventable than we give them credit. And I think more than what we kind of general knowledge.
Yeah.
I broke most of this down into no meds and meds. So obviously we can prevent with meds, and I'm going to talk about that after in a second. But I really want to highlight the things we can do without medication. So prevention without medication is mainly identifying their trigger and avoiding it. So there are 3 main triggers. This goes back to the risk factors we talked about before: exercise-induced, allergen-induced, and cold temperature of air. So specifically with exercise-induced, you're going to want a proper warm-up before exercise, because a proper warm-up can hold off symptoms of asthma for up to 2 hours. It actually creates a refractory period, which is really awesome. Now, I do want to point out that normally asthma attacks happen in the first 6 to 8 minutes of exercise. So by warm-up, I'm not saying like, hey, go run on the track. I'm saying like, get your blood flowing, get air moving in your lungs, get your body moving, start off slow, and, kind of gauge with what is this patient's threshold. How far can you push it before they start getting symptoms?
And I was going to say, a good trick for me, and one, I've been lucky because, track athletes do a very good job of warming up, compared to other sports. But I just tell them, hey, if you start at a certain time for your warm-up, I would say maybe you start a little bit earlier and extend that warm-up so they can start off slower and build into the warm-up. And that's kind of been the trick for me with those asthmatic patients.
Mm-hmm. So long-term, the great thing that we know about asthma is that you can increase the conditioning of this athlete, and it can increase their maximal aerobic power. This is essentially increasing tolerance to the stimulus before an asthma attack. So let's say before, now I'm all about arbitrary numbers apparently, but let's say you're at a level of a 5 before you get to an asthma attack. With conditioning, you can raise that number to, like, let's say you're at a 7 or 8 before you get to an asthma attack. So you can be doing this is an arbitrary number, remember. So you can be doing workouts at a 6 level, whereas before that's where you were getting an asthma attack. But now, because you're conditioning, you're increasing that power.
It raises your threshold.
Exactly. So I also gave this presentation at, like I said, the weekly Zoom meeting we do with some other athletic trainers, put together by Scott. And one of my colleagues, Maddy, at the end of my presentation, was talking about how incline training helped her. And so I asked her to put it into words, and she was magnificent, and I'm so glad that she's able to find relief from some of this, and I wanted to share it with you guys. So Maddy wrote, I was first diagnosed with exercise-induced asthma when I was 12 years old. I always struggled with cardio-intensive sports and cold, dry weather. Remember, that's a risk factor.
Exactly.
And it becomes easy to use it as an excuse to not to do certain things. So moving forward to college, I got really into hiking. I noticed that any slight increase in my incline, my asthma would kick in. I would struggle to continue and had to take frequent breaks. But I was also determined not to let something like that keep me from hiking. After multiple hikes, I noticed that my asthma was not as bad, and I was able to last longer with less breaks. I also no longer needed to use my inhaler, which is awesome.
Oh, big time. That's a huge outcome, not having to use that.
Exactly. And something that you can see.
Exactly.
I caught on to what was happening and started to incorporate incline training to my regular routine. That mostly just entailed incline jogging on the treadmill, stair stepper, and more hikes. Beautiful hikes. I've seen the pictures of her hikes.
Oh, that's awesome.
It's been years since I've needed an inhaler and no longer experience asthma symptoms on a hike. Oh, that's awesome. The cold, dry weather still gets me, though. Again, risk factor.
Yep.
Now, she also wrote, I want to point out the incline is different than elevation. If I were to do a 3-mile hike with 2,000-foot elevation gain at 1,000 feet elevation versus a 3-mile hike with 2,000-foot elevation gain at 9,000 feet elevation, I would have a very different experience that is unrelated to asthma and more in the realm of blood oxygen saturation. There's less oxygen at a higher elevation that will affect even the healthiest person if you are not used to it. At the end of the day, you have to remember that your lungs are a muscle. I love that she wrote that.
Yeah.
I trained them to adapt to something that was seemingly an attack. If I were to run 10 miles with no training, my calves would surely cramp and feel terrible the next day. That doesn't mean don't do it again. Just be smart about how you train for it and listen to your body.
It also brings up a good point because, we're not saying that the lungs are literally a muscle. That's not, we don't want anyone coming in saying like, hey, that's not true. No, it's a figure of speech as far as saying that the lungs are able to adapt like muscle would adapt.
Mm-hmm.
And there's actually research going into some of these topics as far as training diaphragm and working on inspiratory muscle function actually improves asthma outcomes and symptoms. So the fact that she's seeing this improvement with incline training, it makes sense, and it just shows you that if you're able to train those muscles that support breathing, you're going to get better outcomes.
Exactly. So now we're going to move more into the allergen-induced risk factor and how to prevent that. So specifically with allergen-induced, your best bet is going to be to find an alternative practice locations if there are airborne allergens. Now, of course, this is not always taken well by coach, right? But some conversations that you can be having are, if you have an outdoor sport, maybe work to schedule when the pollen count is lowest, which is usually in the evening. If you're indoors, you're a little bit luckier. You got to make sure that you have good ventilation and air conditioning. So in the National Athletic Trainers Association position statement, they talk about using the National Allergy Bureau website, which I think is like AAAI.org.
Your guess is as good as mine.
It's something similar to that. It's in the position statement if you want to find it. I found that our closest location on the website was 2 hours away. So I did try to find something else that does pollen counts, and I found that WeatherBug, the app, that's what I usually use. It does pollen counts as well. And then lastly, for prevention without meds, is the cold temperature of the air. So with this, it's important to talk to the athlete about breathing through their nose rather than their mouth. It attempts to not only warm the air before it gets to the airway, but also humidify the air. So remember, cold and dry air is also a big risk factor.
And it makes sense because if air's going through your nose rather than your mouth, it's a longer pathway to get to the trachea.
Exactly. Also, breathing through the nose acts as a filter for irritants. So I know that this is not specifically for cold temperature air, but kind of what we were talking about before. And just remembering, as far as like some of those more high-risk sports are going to be hockey, ice skating, skiing, anything in that cold realm, you have that cold, dry air. So it's not saying that if you are participating in the sports, you are going to have an asthma attack. I'm not saying that at all. But just as if you're working these sports, this is a perfect storm of risk factors for these athletes to have an asthma attack. Something that was recommended in the position statement that I went on to look into through other sources as well is using a scarf over your mouth or a mask. And specifically because of COVID and exercising with masks, I wanted to touch upon this a little bit more and more in depth, so we're going to go over that later. But just remember that this is where it came from, is starting to talk about the cold temperature there.
So we talked about the prevention options without meds. What are the options with meds? So
obviously, preventing asthma attacks with meds is going to be a lot easier because there's a lot less you have to think of. There's both short-term and long-term control. Short-term, we're very familiar with. I'm sure a lot of you guys have heard of albuterol or a rescue inhaler. these have an onset of 2 to 15 minutes and they last 2 to 4 hours. So this is typically, you want to use it like 10 to 15 minutes prior to a game or to practice, just to get that medication in your system that helps prevent that asthma attack. Long acting are a little bit different. They're used for long term, so short acting, short term control, long acting, long term control. Long term control as in 12 hours. That's what it means. These super, super important. These are not rescue inhalers. So these are going to be treating more of your underlying inflammation. Again, keyword inflammation. And they're often paired with a corticosteroid, which we know, corticosteroids.
Anti-inflammatory.
Exactly. So the onset of these take 20 to 30 minutes, and like I said before, they last up to 12 hours.
And when you see how these are administered, a lot of them are in like pill form and they crush it and then they inhale the crushed med. So you can at least tell how this is not a rescue inhaler. In my experience, a lot of times with those athletes who get fairly moderate symptoms of asthma, when they're put on a long-term asthma plan, the outcomes and the improvement is huge. That's what I've seen. We talked about how we're preventing asthma attacks. What are the risk factors? So as a clinician, what do we do when we have someone that's in an asthma attack?
So the first thing we want to do is identify it. You want to make sure that you know what you're treating. And once you identify that it is an asthma attack based on what we were talking about before with the signs and symptoms, which are?
Those are like your coughing, wheezing, chest tightness, difficulty breathing.
Once you determine that it is an asthma attack, you can do one of two things. So you can either treat it with meds or without. But first I want to talk about what happens if it goes untreated.
And I think that's something that not a lot of people do talk about. And that's why a position statement was put out about this. And I believe the position statement on preventing sudden death even has asthma in it.
This is a respiratory attack. If you have an asthma attack that goes untreated, you can have things such as lack of oxygen in the blood, which is also called hypoxemia, metabolic collapse, which is death of cells and organs. That's really serious. And it can even affect your heart in acute right heart failure. Also, because, like I said, it was respiratory, this is a respiratory attack, you can go into respiratory failure, which is cyanosis, confusion, poor air movement, sweating, or using accessory muscles to breathe. So, now that we know what happens if we don't treat it, it sounds like we want to treat it, right?
It sounds like a good idea. You probably should treat this.
Exactly. So, first, we'll go over how to treat without meds, which is really helpful, and what I did with that athlete who came up to me and she didn't have her inhaler at first. And this is where I want to go back to those risk factors and especially pay attention. If you know what their risk factor is, and if you know what causes that asthma attack, then take them away from that source. So remember, if they have allergens or pollutants and that's what causes them to go into an asthma attack, then you're going to want to get them into an area that has limited exposure to those. Because if you are trying to fight the inflammation and the stimulus is still present, you're just making an uphill battle for yourself. So once you find out what the stimulus is, try to limit that. And then have the patient sit down. This is really important because you don't want them to have them lie down. It will actually make it harder for them to breathe.
And when you think about it, it makes sense. Gravity pushing on that thoracic cavity.
And it's harder to get that inspiration. Next thing is calm the patient. And I included this because I know that you guys probably know this, and I just want to point it out again. When you're talking to someone who's not calm, they're not going to hear anything that you're saying.
And it just makes the condition 10 times worse.
Exactly. So you're going to calm the patient, and then once they can calm down enough to understand what you're saying, you're going to coach them through nose breathing. So this is in through your nose and exhale through a straw. Not a real straw, a figurative straw. So like puckered lips. So it would be inhale through your nose, exhale through puckered lips.
And that goes back to calming the patient as well. That is a great calming stimulus.
And it lowers heart rate and all that. Breath work is great. We should probably look into more of that too.
Absolutely.
the reason why you want to exhale through puckered lips, or like exhale through a straw, I like to say, is because it increases the pressure throughout their airway, which allows them a higher chance of getting those bronchioles back open and helping limit that asthma attack and kind of combat what's happening with the inflammation. If you have a pulse ox, this is a perfect time to use it. You can assess their oxygen saturation, so you can kind of see what percent oxygen they're getting. If they're at less than 92%, that's when you're going to want to administer supplemental oxygen. Now, if they do have their own inhaler, this is when you would use a rescue inhaler. So, bronchodilators reduce bronchial spasm. So that's basically what is in the short-acting beta-2 agonists, such as albuterol, what we were talking about before, or anticholinergics.
I'm glad you were able to say that, because I was reading it right now, and I was just like, man, that'd tie me up.
Tongue just tied you up.
Yeah, exactly.
So this is also called a metered dose inhaler. So if you hear that, it's the same thing. So I also want to go over how to administer it. Did you learn as a student how to administer?
Yes.
Okay. So I don't know if where you guys stand, but this is also definitely a good review if you don't know. Or for our students out there. So you're going to take the inhaler. A lot of times, if you have an asthmatic, they should know how to use their inhaler, but a lot of times if you're having an asthma attack, that's really scary and you might not remember, and it helps to have someone coach you through it. So you're going to take the inhaler and you're going to shake it. The shaking activates the medication.
Yeah, it gets it all spiraling in the
chamber.
Canister, yeah.
Yeah. So, and usually you're just only 5 seconds. You're going to shake it for 5 seconds. Then, I like to think of this part like CPR. What do you do when you give a breath in CPR?
Tilt their head back.
Exactly. So you're going to open that airway by lifting the chin just slightly. And then you're going to prepare with an exhale. The way to remember this is because the medication is taken with an inhale, so you're going to have to exhale your breath out to start. Once you do that, you're going to take off the cap. There's a cap, so make sure you take it off, otherwise the medication's not going to go anywhere. And then you're going to seal your lips around the base of the inhaler.
Now, also, it is preferable if you do have a spacer to use the spacer and then your lips go on the other end of the spacer. So that is ideal, but the reality is a lot of these athletes don't use a spacer.
Exactly. I, 9 times out of 10, don't see them using a spacer.
But it is more effective, so keep that in mind.
Yeah. So you're going to seal your lips either around the base of the inhaler or the spacer. And then once you're ready, press the top of the medication, and then you're going to inhale at the same time. You want to inhale that medication. It's trying to get into the airway. This is the hardest part. You have to have them hold it for 10 seconds. I think that part's missed a lot.
Yes.
And if you think about it, imagine having you're in respiratory distress. How hard is it to all of a sudden have to hold your breath for 10 seconds?
Exactly. That's very difficult.
And then once they do that, they're gonna exhale, obviously, because they had an inhale. That's natural to exhale. And then the medication is all gross and usually gets on your tongue, so you're gonna want to rinse with water. I know that took a long time to explain, so I just want to break it down. Or do you want to break it down?
No, go ahead, babe.
So shake inhaler first. Seal your lips around the inhaler. Press the button, inhale for 10 seconds, exhale, rinse, and repeat. And you can repeat this up to 3 times in an hour.
So what happens if you do your 3 doses and it's been an hour and there's no improvement? What's your next game plan?
So our next game plan we'll talk about in whether we should be seeing a physician or whether we should be going to an emergency room. I'm going to give you a hint. You're going to go to the emergency room, but I'm going to talk about the differences in that in a second. Like I said, it's difficult to hold your breath for 10 seconds. So let's say someone doesn't get a good inhale of the medication. You are allowed to do another administration, but in order for it to be effective, you want to wait around 60 seconds so that it's maximally effective.
So within the asthma management plan, a lot of clinicians or a lot of athletes themselves have been using a device called a spirometer. Can you touch on what exactly they're using it for?
Yeah, so spirometer is a lot different than inhaler, especially in the fact that an inhaler, you are taking inhalation of medication, and a spirometer is actually not a treatment. A spirometer, you are blowing out to determine your maximal lung capacity, essentially. It looks at long-term lung function over time. So the reason why someone would use a spirometer is because they're wanting to test what their capacity is at a certain time. So this is something that you can be using. I like to use it before we even start the year. So this is something you can do with your pre-participation exams. If you know you have someone coming in with asthma, you can assess their lung capacity ahead of time.
It gives you a good baseline of where their lung function's at.
Exactly, and it also helps you with a return to play decision if you decide to use this and know their baseline. The way you can do that is, well, first let me talk about how to use it so then we kind of have a better understanding of what the values mean. So the spirometer will give you a value between 0 and 600 liters per minute. And what that means is it's a peak exploratory flow rate. So, and I know I have to explain that too. So what that means is basically at one moment, how much can you blow out of your lungs at one time? The way you test this is similar to the inhaler. You're going to seal your lips around the edge of the mouthpiece, and you're going to blow out all of your air as fast as you can, usually in like a 1 second blow is what they do. And you're going to blow out as hard as you can. You're going to record the number it gives you. And I like to think about this as like in track, what is it, long jump?
Yeah.
So in long jump, when you do long jump, how many trials do they have?
Depends on the event. You basically get 6 jumps.
So in spirometry, you only get 3. But I like to think of it similarly because in long jump, you're not going to take the average jump, right? You're going to take the furthest jump that athlete was able to complete.
Man, if you took the average, there'd be a lot of sad athletes out there.
Exactly. So this device is used for lung function. So you are going to take the highest number, not the average. And I think that's super important to remember because a lot of times people think, 3 numbers, we're going to take the average.
And it saves the clinician from having to do math.
Exactly. So, but there is a little bit of troubleshooting. So, like, because the indicator is on the top usually, you have to make sure your finger's not on it. Because if you blow out and your finger hits the indicator, then it's going to mess with your results, right? So, through your 3 trials, I tried looking for, like, specific numbers to give you guys. But because height, age, race, gender, all of those have to be taken into consideration when determining what, like, quote unquote normal lung function is. It wouldn't give me an actual like number value, but instead I found that the CDC actually has a reference value calculator that is based on age, race, gender, and height. So I'll put that in the show notes or description, whether you're watching on YouTube or listening to the podcast. It's down below, so you guys can use that to your advantage. If you are using this for return to play, or if you're using this to see like if medication is working or different ideas similar to that, your green number is going to be 80% higher, 80% or higher of your best value. So let's say your best value is 400 liters per minute. 80% of that is going to be your green light. You're good to go. Your yellow light is going to be 50 to 79% of your best value, and that's when you're going to want to seek change in your medications.
And that goes back to monitoring, again, the long-term function.
Mm-hmm. Asthma goes beyond just asthma attacks, right? And then red, this is bad. This is less than 50% of best. And usually this is going to be seen during an asthma attack. The literature was saying people use spirometry during an asthma attack. I really clinically do not foresee myself bringing out my spirometer during an asthma attack to determine how well you're breathing, because I can see that. But if you want to be by the book.
And it is a tool to document return to play. You know, if you're kind of iffy about should they really return, that's a tool you can use. Like, hey, if they are 80% of what their best was, okay, they're probably, their lung function is now within their normal. They can go and return to play. So when do you determine that an asthma patient needs to see a physician?
I think the biggest thing I would say is if symptoms are not being well controlled. So, obviously, this is not talking about like having an asthma attack and their symptoms are not well controlled. We'll talk about that in a second. But this is talking about like, let's say you have an athlete who is using their inhaler 3 to 4 times per day.
And that's a lot.
That's a lot, I would say. Let's say their medications are not maximally effective. They used to be able to get them through X, Y, and Z, and suddenly, like, they're having difficulty getting through just X and Y.
And also that they're now starting to get those symptoms in the evenings or in the mornings.
More difficulty sleeping, any of those symptoms that we talked about before. If their treatment plan needs to be reevaluated, obviously, to send them to a physician, and usually this is about every 6 to 12 months.
And is there a particular physician that you're sending these athletes to?
I'm glad you asked that because I feel like in school when we were going through, a lot of times they would say like, oh, refer. And I was like, refer to who? So I looked a little bit more into this. You can always refer to your primary care physician. They're going to know who to go to. But if your athlete has like a PPO or something that they can go direct access to a specialist, you can see an allergist or a pulmonologist.
And I was going to say that definitely runs into it to where if the school only covers athletic injuries and you have to use their primary care, the kids with HMOs, they're going to have to see their primary care before they go on to see an additional clinician.
Mm-hmm.
So what about in an emergency situation? How do you determine that this athlete, he needs to go now?
Do you remember how many times you can give a rescue inhaler in an hour?
It should be 3.
Exactly. So I would not probably wait an hour if someone's symptoms are way out of control. My rule of thumb to send people to the emergency room or to call 911 is, can I handle this? If the symptoms, even if you're the best athletic trainer and you've done everything, sometimes the symptoms are just beyond what you are capable of controlling at that moment. You've coached them through nose breathing. You've given their inhaler 3 times, but they are still having respiratory distress.
Or even getting worse.
Especially that. They need to be seen. They need to have further interventions. So this is them breathing more than 25 breaths per minute. This is increased wheezing. This is uncontrolled cough. This is abnormal abdominal involvement. Nasal flaring, inability to speak in full sentences. That one especially, that's what I was seeing with the athlete who I was talking about in the beginning.
Mm-hmm.
I had to talk to some bystanders to get a better idea of what was happening because she was not able to verbalize to me.
Yeah, that's pretty severe.
Mm-hmm. Luckily, we didn't have to send her anywhere. I was able to coach her through nose breathing, and someone else went to go fetch her inhaler, and so
Awesome.
We were able to get that. And she was already well versed in using her inhaler, so because of that, it made it an easy treatment.
Yeah.
Management.
So I know we already touched on return to activity a little bit, but can you just give us a nice overview of what you should take into account when returning to activity?
So I want to emphasize that this is going to be heavily individualized. It's going to be based on symptom resolution. You want to have normalized breathing rate, and you're going to want to have a normal high oxygen saturation. And if you have their baseline, compare it to their baseline. If you have access to the spirometer, like we were saying before, and you know what the athlete's baseline is, they should be at least 80% of their best to safely return to play. Remember that 50 to 80% before, that's like yellow light. That is going to necessitate another dosage of medication, and then less than 50% is going to be an emergency condition.
Can you just sum up for the clinician what they should be doing when they have an athlete that has checked, yes, I do have asthma?
I love this action item.
Theme of this podcast is action items.
So exactly, what do you do when you have an asthma patient? Well, you want to identify their trigger. I hope I said that a million times already. Identify their trigger, because if you know what causes their asthma attack, you can avoid that, and then you can forget the rest of what I just said in the last few 30, 40 plus minutes, right?
And I'd also add, with identifying their triggers, is look at what meds have been prescribed to them. Are they just prescribed a rescue inhaler, which you'll talk about, but also do they have a long-term management plan? Do they need a plan that includes a long-term medication?
Mm-hmm. And then you're going to want to create a written emergency plan. Now, this is best practices. This is something that was talked about in the position statement as well. In this plan, you should include how to treat or manage an acute asthma attack, when to administer meds, and when to call 911. Doing this, you're going to want to touch base with your physician, your team doc, or the athlete's primary care about long-term management plan as well as acute asthma attack treatment. This is something that I think is probably the most well-known in our traditional sports setting, is that you're going to want to have a rescue inhaler available during exercise.
That is one of my biggest pet peeves, is when my kids do not remember their inhaler. They're like, oh, I left it at home. It's not doing you any good at home.
Exactly. And so for this reason, a lot of times athletic trainers have a backup that, remember, an inhaler is a prescription. So you technically should only be using it for that specific patient. So let's say John has asthma. I'm going to ask him if he has an extra inhaler that I can keep in my kit, so that in case he leaves his at home, which is very easy to do, I do have a backup and I don't have to rely on treating him without medication, which now we know how to do.
Exactly.
Also on this point, I really want to touch upon that you are not just using this inhaler or having this inhaler on you for games and practices, but also lifting. Lifting is also exercising, and even though we're not usually in the weight room watching them, we should be paying attention that does increase oxygen demand.
And don't forget the chalk.
And the chalk. Exactly. And then, of course, if you have access to baseline spirometry testing, I would do baseline spirometry testing, especially if you are going to be doing using that for return to play.
So this is going to be a big topic, especially because of COVID-19. But what do you do with the asthmatic patient in terms of wearing a mask?
So asthma patients can wear masks, and it's actually recommended by the literature to wear a mask. And this is pre-COVID. This is not talking about preventing the spread of disease. This is talking about preventing an asthma attack. So I'm not going to tell you that and that be the end of it. So I'm going to go into the physiology and the why behind it in a second. But first I want to do a little disclaimer. If masks are impeding your ability to breathe, they should not be worn. This is especially true with exercise-induced asthma, because remember, exercise-induced asthma, you are having vigorous exercise is the reason why you're going into an asthma attack, and obviously masks are not going to prevent that. Now, if someone does go into an asthma attack during that, you're probably going to need to take their mask off so they can get a full, unimpeded breath of air. Now, besides that, all of this should be individualized, as with everything we do.
Yes, absolutely.
So, going back to the 4 main causes of asthma attacks, we have exercise-induced, allergen-induced, cold, and dry air. So, masks, I already talked about how masks don't address the exercise-induced asthma because they're not going to prevent you from exercising vigorously. So they're not going to prevent an EIA attack. But they do address some of the underlying problems, so that's really important to note. If the asthma attack is due to respiratory water loss or dry air, then masks actually capture the water loss and allow for re-inhalation of that water to keep the airway moist.
And everyone's felt that when wearing their mask. It starts to get a little muggy and warm in their mask.
And the first time I saw anything about masks and asthma was in the NATA position statement, which is what made me want to look into further research about this. They actually wrote, I don't remember if it was in the position statement or if it was in one of the other articles I looked at, but they actually wrote, it is unfortunate that even though masks are a great way to prevent asthma attacks, a lot of athletes won't wear them in the hot, humid areas.
Yeah.
Which makes sense.
Yeah.
Because it's keeping your airway warm and moist. So again, if the asthma attacks are usually due to the cold air, then masks capture the heat lost through exhalation and keep the airways warm, like I just said. If the asthma attack is due to pollutants or irritants, then masks are a perfect filter for that. I mean, look at Galen Rupp.
And he's a gold medalist distance runner.
And he runs with a mask. Because of his asthma, he's trying to keep those pollutants and irritants out.
That dude's fire, by the way.
So essentially, wrapping it up, we're talking about asthma use and masks. How do masks prevent asthma attacks? Well, they keep the airway warm and moist, and they keep pollutants and irritants away.
You're hitting all the risk factors right there.
Exactly.
So I know, especially now with homemade masks, becoming more popular, and it's been a really good thing, but I know some people have difficulty wearing it because when they breathe, it like goes into their airway and like goes in their mouth.
Okay, I want to say this is the most annoying thing ever, right? I think we can all agree on that. But there are some ways to keep the mask structured and basically make it not feel like you're wearing a mask.
I feel like this is a life hack alert.
Life hack, AT life hack. So there are some different ways that you can get around the mask collapsing into your face. First way, the cheapest way, is at the craft store. They have this stuff called plastic canvas, and it basically looks like a grid that's made of plastic.
Mm-hmm.
They're usually like, I want to say they're about the size of a paper, so they're like 8.5 by 11. Totally easy to cut. You can cut down to size. They're usually about $1. Sometimes they're even 70 cents, I've seen. So go to the craft store, get one of those, cut it to fit inside your mask. If your mask has a filter pocket, that's perfect. You can slip it in the filter pocket. If not, I saw someone on Facebook use binder clips.
Oh, that's brilliant.
Yeah, to hold it on their mask. And basically what it does is it provides structure in that mask so that when you put it on your face, it does not collapse in on your face and you're still able to take breaths in and out. Something, if you're not so creative, if you do not want to cut plastic canvas.
I am not very crafty or creative.
This is, it's not a really difficult thing to do, but there are things called lipstick protectors or mask forms. They're pretty cheap too. I don't think they're like 99 cents like the plastic craft stuff. But essentially, these ones do not have to attach to the mask in any way. Some people just have them sit like right on their chin. And basically, it looks like a dome, and it structures the mask in the same way that the plastic canvas would, so that the mask is not coming in and collapsing in on you.
Oh, nice.
Another thing I saw people doing was using those adhesive nose clips and just putting them and structuring them in the mask. The only problem I see with this is that it's going to probably be difficult to wash. Although I will say that I made my own masks, and I did add a paper clip in my own to as serving as a nose piece, and it has changed my mask wearing so greatly because now I put one in Randy's because he has glasses.
Yeah, so it'd help keep my glasses from fogging up.
And I don't wear glasses normally, so I didn't see the need to put mine in. But once I did add a nose piece to my second mask, it actually made it sit on my face so nicely that I don't really have to adjust it at all when I'm wearing it. And it doesn't sit, the nose piece sits right on my face, but because like when I'm talking, it's not moving up and down, and it, I don't feel like, I'm not exercising in it. We do walk every morning, but I don't feel like I'm breathing in my mask.
Yeah.
Like it's just a better fit for me with the nose piece. So play around with that.
All right. So, to sum this up, your favorite thing applicable knowledge.
Exactly. So we want to, almost like a too long didn't read, what are these action items that we need to remember? I just talked for a really long time about this. Maybe your mind kind of went off into podcast world. Let's bring it back. Let's recap. So objectives of this were to identify the main symptoms of asthma, know how to treat it, know when to send patients to either a physician or EMS, and how to determine return to play. So let's start with identifying the main symptoms of asthma. I want you to remember that if you see chest tightness, shortness of breath, coughing, and wheezing, you're going to know that it's a respiratory problem, usually. Sometimes it could be something else. But usually those are the main symptoms of what you're going to see when someone is in an acute asthma attack. Treatment is going to be inhale through the nose, exhale through puckered lips until a rescue inhaler is available. So again, that goes between no meds and meds. You're going to send patients to EMS if symptoms are not controlled after 3 doses of a rescue inhaler. You're going to send patients to a physician if they're using their inhaler more often than normal, and if you notice that their medications are not as effective. And then returning to play is going to be highly individualized, but usually it's going to be when symptoms have resolved or when your spirometry testing is at least 80% of best.
Nice. So, how was your first education episode that you ran?
I think it went pretty well. I think we went over a lot of. Hopefully, I mean, I know that asthma is a big thing that we see pretty frequently, I would say. I know that a lot of people, this is going to be a review. I hope that with the masks, though, I hope that it gave a little bit of a new light to some clinicians, especially ones who have been practicing for a long time. And then, of course, for our students, I hope that this asthma kind of gives you a better understanding of how to manage this on your own and really what to do if you do have that asthma patient.
Yeah, and please, everyone, remember, join our Facebook group.
So if you can't picture the canvas thing that I'm talking about, we're going to post that in the group as well. So this is a perfect enticement for you guys to join the Facebook group.
And yeah, we also want to hear from you guys and see what has worked for other clinicians. What have you done for asthma and how to manage long-term management of an asthmatic patient?
Or if you have asthma yourself. Like, if I wouldn't have talked about this in the weekly Zoom that we've been doing, I wouldn't have known how Maddy has been using incline training for her personal asthma and how she's gotten around that and how it's worked for her. So we want to know from you guys what's working for you, what's working for your patients, what have you seen clinically, what have you seen in the literature. Do you agree with things that I've been saying, or you can disagree too? That's totally okay.
Yeah, we'd love to create a discussion, and that goes back to what we want our Facebook group to be. We don't want this just to be a place for us to post. We want this to be a community. We want to hear your guys' case studies, any funny memes about athletes or athletic training that you have, or anything that you want to share that you think other athletic trainers would love to see. We would love to have that on there. We want to create this kind of community.
Exactly. That's what community is. Community is not us just posting and you responding. Community is everyone participating and sharing what they want to share. So next episode is going to be travel stories. We're super excited about this, and it's going to lead into a very special interview.
Oh boy, do I have some good travel stories.
So speaking about stories, if you're new, every other episode we do stories that showcase athletic training, highlights, ups and downs. And then each odd episode we do interviews or education like we did today. So what we want you guys to send in to us, our email is atcornerds@gmail.com, also in the show notes and description. We want you guys to send in your crazy weather stories, working with other healthcare professionals, crazy mechanisms of injury, and getting injured on the job. And this could be anything. These could be funny stories, they could be serious stories. Anything relatable that you want to share with other clinicians, we want to hear it. We want to hear what you guys have been doing working as an athletic trainer. Also, I forgot to add that if you are interested in reading more upon asthma and figuring out what I use as my citations. They're too long to put in the show notes, so what I'm going to do is put them on our website instead, and that's also going to be in the show notes, or you could just go to our link tree, which is linktr.ee/atcornerpodcast, and there should be a link to our website. In the blog section, that's where I put all the citations for all of our education episodes. So if you're ever looking on more information on asthma, I have, I think, like 8 or 9 citations here. So that's a good place for you to start. Have anything else to add?
Yeah, I think that's about it. Thank you for helping us showcase the profession of athletic training behind the tape. Bye.